we'll move on to the next one. It's my pleasure to introduce Dr. Nabibah Tayob from Dana-Farber Cancer Institute. Dr. Tayob is the co-director of Biostats and Computational Biology, core of DFHCC BreastSpore. She's an active collaborator on research projects with investigators and co-investigator on multiple NIH-funded projects. She'll be reviewing biostats considerations for precision medicine. Dr. Tayob.
Thank you. Sorry, I can't see my slides. Oh, okay, great, thanks. So thank you to the organizers for inviting me to participate in today's clinical research workshop. I'm looking forward to a really exciting week ahead and very informative. Today I'm going to be discussing statistical considerations for precision medicine. There is obviously a great deal of interest, as we've heard from the other speakers today, in tailoring our clinical interventions to each patient. As a biostatistician, my interest is focused on how to design studies to evaluate these interventions and what considerations to focus on during analysis of these studies. We are currently using precision medicine across the breast cancer continuum, and there is obviously scope for improvement and in many settings. So for example, we use patient characteristics, genetics, family history to risk stratify patients for early detection of cancer. So we can tailor our screening based on patient's risk, and so patients who have average risk versus high risk have different types of screening. How to screen, when to screen, the modality of screening can all be personalized based on patient risk. Once you have a cancer diagnosis, we have a number of predictive and prognostic biomarkers, such as hormone receptor status, HER2, other genomic tests that help guide our clinical interventions and have improved patient outcomes, but there is obviously further scope for improvement, and that is of a great importance and interest. In addition, we could even think about, as we just heard about minimal residual disease in our first talk today, that we could think about introducing precision medicine throughout the cancer treatment phase. So for example, monitoring of recurrences, predicting for recurrence, tailoring interventions based on risk of recurrences. And so we are The goal of precision medicine is to right-size our treatment for each individual patient. We want to give them enough of a clinical intervention that they will improve survival, but not too much of an intervention that has associated impacts on their quality of life. Oops, wrong way. So most of our precision interventions require some kind of measurement of the characteristic of the patient, and often we use the term biomarker. So what is a biomarker? It's a biological molecule that is found in blood, other bodily fluids, tissues. It's a sign of an abnormal or normal process. It's a sign of a condition or a disease. Essentially, a biomarker can be used to see how well the body is responding to treatment or disease or condition. There are also other terms for it. We use the term molecular marker, signature molecule, so forth. Biomarkers allow us to classify patients based in the context of cancer. We can use it across the continuum, risk stratification, early detection, diagnosis, prediction, or prognosis. These definitions from the NCI doesn't include biomarkers obtained from imaging studies, but I would actually put that in the category. To me, a non-invasive radiomics marker could potentially also be a very useful marker, and so it should be included as well. The important thing to think about, though, is that these biomarker assays themselves are important, and we want to understand what's the analytical performance of these biomarkers before we introduce them. So, and as we analyze these results, these are important considerations to keep in mind. So, reproducibility of the assay. Does the assay give the same result each time it's been run? Robustness. If you're using different labs, are you getting different results? Limits of detection. So these are really important in our research as we're developing these strategies, because we have potentially sometimes using what we call research assays. We're not necessarily going to report these out to patients. It might be for our retrospective analyses of a completed study. But the analytic performance of the biomarker will potentially be very different in a research-based assay compared to our FDA-approved assays. And this is important because our goal of precision medicine is to use difference in biomarker levels to be associated with patient outcomes. However, if there's lots of variability in the assay that are due to these analytic factors, then we're clouding our signal with a lot of noise from these assays. And so it's really important when you're studying these precision medicine interventions to be aware of what stage of development your assay itself is at. And so, because you need to be clear on what are the sources of variability when you're evaluating it. So when we evaluate biomarkers, we want to be clear on what the target population is for the intended clinical use. We need to define exactly who we're going to use this biomarker on, and that needs to be the focus of our study population. So, for example, if we're thinking about prognosis of patients with early-stage HER2-positive breast cancer, if we're thinking of diagnosis of minimal residual disease in those who have completed neoadjuvant chemotherapy, we need to have a very well-defined population so that we can evaluate it in the intended clinical use. We also need to think about how we're going to use the biomarker, and that's where the kind of understanding what's the current clinical practice becomes very important. How is this biomarker going to change our current clinical practice? So, for example, if the current practice is that for a particular intervention, no one is getting the clinical intervention, we are thinking about a biomarker that will then be used to define a rule-in test. We want to know who should be getting a clinical intervention that they're not currently getting. And so therefore, we need to be very concerned about controlling how often we do a clinical intervention in those where it's not necessary. We call this the false positive rate. If, on the other hand, the goal is that everybody is currently getting a clinical intervention, but we want to identify who are the patients that can avoid this particular intervention, then we want to design a rule-out test. We want to control how often we falsely do not do the clinical intervention in someone who actually did need it. And so that's our false negative rate. So thinking about what's the current clinical practice, how is this biomarker going to change the current clinical practice, then helps us decide what are the various factors that we need to be considering. And the decision-making always involves trade-offs, and understanding the consequences of a false positive and a false negative test become very important as we're balancing those trade-offs. So although today's talk is not specifically about early detection, that is where I started my research area, and so I do have a little kind of a bias towards it. But I do think that the Early Detection Research Network at the NCI has proposed a 5-phase approach that for evaluating biomarkers that I think, although they focused on early detection, they actually apply across in every setting, and they really have a very important role to play as we think about these studies. Their goal is basically that we have increasing levels of rigor that are required to move to the next step of validation, and a very systematic approach to increase the likelihood that we actually have a biomarker that can impact overall survival. So the way the approach goes is that for your phase 1 at the bottom of the pyramid, you've got the preclinical exploratory studies. So you've got promising directions are identified. In those contexts, we often will think about very easy to obtain cohorts. So we could think maybe they might even be convenient samples. They might be not necessarily the right exact population that we're thinking about, but we're just identifying preclinical potential promising directions, a promising biomarker. But when we get to phase 2 and phase 3, these are retrospective studies. So they're retrospective studies, but we're still, now we're in the setting where we have a clinical assay in place, so we have more thoroughly evaluated the biomarker and the assay itself. Then, in the context of early detection, when we're thinking about identifying patients with cancer, we in a phase 2 study, you have you're asking the question, can the biomarker detect patients with cancer right now? And so that you can do in a case-controlled study. It's a single time point. It's a more feasible study potentially. But for phase 3, you are asking the question, can the biomarker identify preclinical disease? Can the biomarker identify cancer before it's presented clinically? And that requires a more resource-intensive longitudinal cohort studies. So you can see as you're moving up the pyramid, the rigor of your cohorts and your studies are increasing because you're moving the biomarker closer and closer to its intended clinical use. So the important thing also to remember is that in these retrospective studies, there's the opportunity to potentially combine biomarkers. Think about how exactly you would be using the biomarker in this clinical context, because in the phase 4 studies and phase 5 studies, once you're implementing the biomarker and acting on the biomarker, you have to have all of these things locked down. So let's say you're using multiple biomarkers, you need to understand how you're going to combine these biomarkers, what is the rule for making a decision on these patients. And so the goal is that you thoroughly evaluate your biomarkers in these retrospective studies before you do any implementation of these in these prospective studies. And in the context of early detection, a phase 4 study is potentially a single-arm study, which is a little bit more feasible. It's a prospective study, you're acting on it, but you may not have, your endpoint might be a more short-term endpoint. But then the phase 5 study is a randomized controlled trial, and your goal is overall survival as your primary endpoint. So is the biomarker going to actually impact on overall survival? So this is a kind of the pipeline, right? Like you want your biomarker, you're increasing the levels of rigor as your biomarker moves up through the hierarchy of these rigor, and hopefully by the end of it, you do actually get a biomarker a randomized trial that has a positive result. Sorry. Okay, so the other paper that came out of the EDRN that I think is very important for people to consider is these probe-compliant designs. So these 4 retrospective studies, these are for retrospective studies of biomarker evaluation. And the key here, probe stands for prospective specimen collection, retrospective blinded evaluation. So prospective specimen collection means that you collect your specimens. The study outcome is only determined after your specimen is collected. When your specimen is collected at the time, you do not know the status of the patient. And then you have then a standard operating procedure for specimen collection, storage, processing, storage, and retrieval. And this is getting to the point I was making earlier, that your goal is to find the signal of a biomarker association with outcome from the noise. And this is trying to control the noise as much as possible so that you truly identify a signal. And so by having a standard operating procedure and controlling this, you're more likely to identify a true signal if it's there. The other aspect that they recommend is blinding and randomization. So blinding is one of those ones that, especially early in the research and in the biomarker development, there's a bit of a resistance or not as much adherence to this, but it's really important to have blinding for the evaluation of biomarkers. What do I mean by blinding? The person running the assay has no knowledge of the status of the assay, the patient, what the patient's outcome is. So in this retrospective studies, we already know patient outcome when we're sending the specimen for processing, and so we actually, for evaluation of the biomarker, and so, but the person who is physically running this test should have no knowledge of this, and in general, hopefully the entire lab, but that whoever should not have any knowledge of this. This keeps any human elements that can be introduced out of the equation, and it helps ensure the robustness of your evaluation. Randomization is another key step for improving robustness and for the goal of identifying signal from noise. The reason to do randomization is, as much as you might try, especially in early in the biomarker development, as much as you might have things locked down, there is potentially some, especially if it's still in a research assay, there are still potentially some technical issues and things. By having a randomization, what you're doing is that you then have, you're not confounding any kind of assay technicalities with the actual outcome. So, for example, you don't run all the patients with a recurrence on one slide and all patients without the recurrence on another set, and then you've completely confounded your outcome with your potential assay bias. And again, in this context, we really want to be clear, how is this biomarker going to be used with existing biomarkers and clinical information? You really want to keep that in mind all the time. So another kind of guidelines that I want to keep in, to bring up is the REMARK guidelines for prognostic biomarkers. So there's a series of basically checklists for when you're publishing results of a prognostic biomarker, and they really do have a lot of the same principles, which shows you that even though I was focusing on the early detection setting principles, they actually apply no matter what type of biomarker you're looking at. What I do want to talk about, though, for when we're thinking about prognostic biomarkers, when we're thinking about biomarkers that tell you potentially about patient prognosis, we do want to think, when we're doing our analysis, we want to keep in mind that it's not only important to understand the biomarker itself, we want to understand the biomarker in the clinical context, and we want to do our analysis in that way. So, for example, it's really important to show not only the biomarker, how the biomarker is separating the groups, but a multivariate analysis that adjusts for important clinical factors that could also explain why the groups are separating. And does the biomarker provide evidence over and above these clinical factors? The other part to keep in mind is that as much as possible, we want this to be pre-specified as we're doing designing out. So with these, let's say, these are for retrospective studies. As we're doing our analysis plan, we want to pre-specify as much of this as possible. And when we're reporting it, we want to be clear of which was pre-specified and which was done after looking at the data. So now kind of going into the clinical trial design spacing. So this is where we're thinking about prospectively looking at these biomarkers. So a clinical trial design for biomarker validation. So the question is, what type of biomarker do we have? A prognostic biomarker will tell us about the patient's prognosis, but it will not give us any information about the choice of therapy. So here we have an example. In both of these cases, we have a prognostic biomarker whereby in those patients with marker high status, they have poorer survival. But in the table on the left, well, it's my left, the patients, basically there's no difference between treatment A and treatment B. And patients on the right, in the table on the right, there is a difference between treatment A and treatment B. But the biomarker is not, the hazard ratio for treatment A, the hazard ratio comparing treatment A or treatment B to no treatment is the same. So the biomarker is not actually able to tell you a prognostic biomarker cannot tell you which treatment is better for a particular patient with this biomarker. For that, you need a predictive biomarker. So a predictive biomarker will predict differential efficacy or benefit of a particular therapy based on biomarker status. So here in the table on the left, we have a purely predictive biomarker. In the case of when there's no treatment, there's no difference between patients with marker high or marker low. But however, when you have marker high, there is a differential benefit. When you have marker low, there is a differential benefit for treatment B versus treatment A. And so this is what I mean by a predictive biomarker. The other, on the table on the right, we have both a prognostic and a predictive biomarker. That's actually probably the setting we're most often encountered with. So this is a case where the predictive prognostic aspect of the biomarker is those with marker high status just have poorer survival overall. But in those with high status, there's no difference between treatment A and treatment B. The hazard ratio is the same. However, in those with marker low status, we are seeing a differential benefit as well for treatment B. So this is often the setting we're in. And in this case, a predictive biomarker can be used to guide choice of therapy. And the way we look for this in retrospective studies is that we're looking for an interaction between the treatment and the biomarker itself, and that being statistically significant. So what does that mean? It means that the treatment effect is significantly different in the two marker groups. So before we design our trial, we need to have thoroughly studied the relationship between the biomarker and the outcome in retrospective analyses. We need to understand these confounding and existing prognostic factors and adjust for them. We also need to keep in mind that there's different levels of robustness in these retrospective studies, and observational studies have biases that are just known, and that ideally, you would have more systematic prospective studies or completed clinical trials, for example, to use for this retrospective analyses. We want to, again, I keep going back to this, but kind of it's really important to have a well-defined target population. And in this case, when we're thinking about the clinical trial design phase, this is really important to think about where will the biomarker have substantial clinical relevance. This is important not only from the translational point, but it's also from a statistical design perspective. The bigger the effect size that you're looking for, the smaller the trial. So as much as possible, you want to have a big impact because that will make your trial more feasible. And then we also need to understand the estimated prevalence of the biomarker in the target population. That again impacts how big the study it needs to be. And again, the evaluation of the biomarker. Is the method of measurement reliable, and is the specimen accessible? In terms of primary endpoints, overall survival is the gold standard for our adjuvant and metastatic settings. Neoadjuvant settings, we would think about response rates, for example, pathologic complete response. Overall survival may not actually be feasible if the trial duration is so long that the relevance is compromised, so we'll often use other endpoints, disease-free, recurrence-free survival, progression-free survival, or response rates. Again, we might be thinking of a series of trials, actually, and so it may not just be a one study, but a series of trials, as I was showing earlier, increasing the level of rigor as we move forward. So just to kind of give an overview of some of these designs, so you could think about an indirect assessment. So in this one, you test the marker. Patients with marker negative are just still randomized between the two treatment options. Those with marker positive are randomized again as well. And in this context, you could design the study to either do separate tests within the marker groups or to test for that interaction and to determine whether there's a significant difference in the treatment effect. The key thing is here is an indirect assessment, which means you're not actually actively acting on the marker status. And so there is also in that sense, it's the rigor of a prospectively collected study, but you're not yet acting on the biomarker itself. So a more direct assessment would be to randomize patients to either a marker-based strategy or a non-marker-based strategy. And then in the marker-based strategy, they would then, based on their marker levels, be assigned a particular treatment. So in this context, a marker level negative gets those with a positive marker get the treatment B, whereas those with marker level negative or those in the non-marker-based strategy get treatment A, which is maybe standard of care. And so this option of a design, one of the kind of things to keep in mind is that if treatment B is superior to treatment A, regardless of the biomarker, then this design will not be able to tell you that. And so you, depending on what treatments you're studying, you have to keep that in mind. And if that's a concern, then your other option is to do a second randomization. So you would first randomize patients to either a marker-based or non-marker-based strategy, and then among those with the non-marker-based strategy, you would randomize them again to the different treatment arms. So essentially here, we're comparing outcomes in the marker-based strategy to the non-marker-based strategy. And we are then identifying whether a random allocation of treatment or marker-based decision making will give us better outcomes. So a lot of what I've been talking about is a single time point assessment of biomarkers. I have a great deal of interest in multiple biomarkers, in longitudinal biomarkers, and this actually happens very frequently. So for example, if we're thinking about many different settings, we would be assessing markers not just at a single time point, but multiple time points. So we can think in the risk prediction, early detection, monitoring for recurrence, and these longitudinal trajectory of these biomarkers could have a lot of information that could help us further tailor the interventions based on not only just the patient's marker at a single time point, but what is the changing trajectory of that marker in that particular patient. And so this is obviously another whole talk itself, but I just wanted to put it out there for people to consider that we want to take advantage of all the information we have available in these patients. So my key takeaways for today is that the context of the usage of the biomarker, we want to think about the context of how we're going to use the biomarker to personalize the decision making. We need to be, as a statistician, we need to be aware of what's the stage of development the biomarker is in as we're trying to identify the sources of variability and separate the signal from the noise. And we want to design the study as much as possible to answer the primary question of interest, knowing that we might not, in our first analysis, get to that final study that we're looking at, but we might need a series of studies that get us closer and closer to answer our primary question. And we want to do a thorough evaluation of our precision medicine strategy before we incorporate it into clinical practice, because there are potential negatives to a strategy that is not well vetted. And so we do want to be sure of what we're doing before we do any interventions in the general population. And so I would say, just to end, work with your biostatistician. This is a team science approach to improving patient outcomes. We need all inputs from all sides to make sure that we are keeping our focus on patient outcomes and getting the best options for our patients. Yes.
Thank you so much for the great presentation. We can move on to Q&A. Microphone.
Thank you very much. Ibrahim from Saudi Arabia. In a trial where there will be multiple measurement of any biomarker, the analysis should deal with the measurement as time-dependent variable.
Yeah.
Despite that, which is basic requirement, proportionality assumption should be tested, which I believe in many trials, good trial, that is not addressed. Would you agree with that?
I think that, yes, there's often the case that we do not test proportionality, and I would say that there are a lot of statistical methods that we should be thinking about that actually don't require proportionality as part of, and are more powerful in settings where we don't have proportionality and we don't lose power. And I think that, we've been focused a lot on this Cox proportional hazards model is very robust, and, we use it a lot, and proportionality assumptions are very prominent throughout clinical trial design, but I don't think they have to be, and I think you can, if you're open to other measures and other ways of doing the analysis, you can hopefully you won't sacrifice as much power, but you get robustness to those assumptions.
Thank you.
Yeah.
Thank you so much.